Right, I think we'll kick off. So welcome everyone. Welcome to another one of the WSA Friday webinars. Really looking forward to this one. As I said earlier, if you were listening, this one is close to my heart for many, many reasons. I am a lifeguard trainer. Been doing that since 2000, so a few years under the bag. But back in the day, Gordon, the presenter for tonight's webinar, used to work with me, and I can honestly say that when Gordon was starting to teach and run the lifeguard courses, it was a revelation for us, because I've never really learned so much, shall I say, from Gordon and his knowledge and his presentation skills. And since then, Gordon's gone on through a variety of different positions, but I'll let him tell you all about that. And which has resulted now as a HEMS paramedic, and is top of the game, really. And I really hope you enjoy this webinar. It's going to be most useful, I think. I just would like to point out that everything we say tonight, it's a guide. There are plenty of courses that you can go on if you wish to take this further. The webinar will be recorded as well, so if you're busy writing away, you don't need to. It'll be uploaded to our YouTube channel and hopefully available to view probably around about Saturday evening, so you can watch it if you log into the WSA YouTube channel. Just a couple of other little things before I hand over to Gordon. Questions, we love questions. Gordon loves questions. If you could send them via the chat function, that would be fantastic. I'll apologize now if we don't answer all of them, but we will try our best. And also, if you could make sure that your microphone is muted, so we don't hear the dog barking in the background. Scheduled for about an hour. Typically, they run for a little bit longer than that. So bear with us. If you do have to leave, don't worry. Like I say, it's going to be on the YouTube channel. So over to my really good friend, Gordon, who's up in the Northeast. Take it away.
All right. Thanks, Chris. Good evening, everyone. I hope you're all well and hope you're all managing with these testing times, which are hopefully coming to an end soon. So as Chris has said, I am a paramedic, a HEMS paramedic on Great North Air Ambulance up in the northeast of England, covering kind of on the eastern coast from kind of Berwick down to North Yorkshire, along to the western coast of Whitehaven and Cumbria. So we have 2 aircraft, and we staff those with paramedics and doctors, and go and provide critical care to the patients in need in the north. So a few kind of apologies from me to start off with. I apologize, first of all, if I get attacked by a dog. He is currently asleep on the sofa after having a walk, so that's hopefully all right. I apologize if you hear kids shouting upstairs because it is bedtime and they've just gone to sleep, but they've been bribed with a massive bar of chocolate tomorrow if they behave, so it should be fine. So what I'm going to cover here tonight for Water Skills Academy is an overview, a kind of a whistle-stop tour, if you like, of some medical essentials that you may come across when you're out paddling, surfing, and enjoying water sports and having a lot of fun out there. So as Chris said, feel free to pose as many questions as possible, and we'll try and deal with them as we come along. So we'll dive straight into it. So a little bit of background about myself. 2 seconds, there we go. Hopefully those slides are moving on, are they, Chris? Cool. So it is back in 1999, I started working for Chris, as he said. That is me on the end of that row of fine people. And that is what Harlyn Surf School looked like. It was a small trailer on the beach where we worked out of. It's definitely grown legs hugely and become the great business that it is today. There is Chris in his younger years as well. So yeah, I do surf. Don't surf as much as I'd like to right now, but have had a lucky career within surfing, and it's opened up so many doors. As Chris said, I kind of started off with teaching surfing and then progressed to training lifeguards and lifeguarding myself down in Cornwall, lifeguarding over in Australia as well. And that kind of took me on a bit of a journey and I came back from Australia one year and thought I need a career. So paramedicine was the career that I chose, and became a paramedic down in Bournemouth, and then moved on to doing other things. So that down the bottom is the aircraft that we fly up at Great North Air Ambulance. I was there for a few years back in 2008, 2010. And then after that, I left and did various things around the world. I worked as a paramedic for the United Nations over in Afghanistan, Somalia, and various countries around the world. Then I started up a water safety company. So whizzing around on jet skis and working with a great group of people, providing medical cover to events, to filming TV shows, etc., and teaching as well. So I did a lot of teaching of lifeguards and also doctors and paramedics. There's a lot of small CPD type courses, which I used to deliver in the UK and elsewhere. So I've been very lucky, very fortunate to been out to Fiji twice, 2 years in a row, providing medical cover for a huge American TV show. And whilst I was out there, I had the luxury of surfing some phenomenal waves, some of the best I've surfed in my life, which was amazing, but also was involved with not only the medical cover, but training the guys who were going to provide water safety out there. So again, from starting all those years ago with Chris at Harlan Surf School and Water Skills Academy, and kind of progressing through that, it opened up so many doors for myself. And then I've ended up where I am today, and very fortunate to do so. And I did a bit of paddleboarding, ended up out in Abu Dhabi for a couple of years, working as a paramedic out there. And there's not much surf out there, but did end up paddleboarding a lot, doing a lot of races. That's my eldest on my back, who's 9 now and surfs himself, and he loves it. And yeah, I just love being on the water. And if I can increase that time as much as I can, then that's fantastic. I do own more than one pair of shorts. You'll notice that in all of those pictures, they are the same shorts, but I do own more than one pair. Right, so let's get into it tonight. So as I said, the lecture is called Medical Essentials. I'm sure a lot of you out there are medical professionals. And again, a caveat, this is going to be a whistle-stop tour, as I said. Now, you might have heard, or you will have heard, things being called basics. I'm a big believer in terminology. And I've not called this medical basics. I've not called it the simple side of medicine or pre-hospital care or whatever you want to call it along those lines. I've called it medical essentials. Now, there's a reason for that. The reason is I'm not a fan of the term basics at all. When you think of basics, you think it's easy, you think it's cheap, you think it's not important. So I'm kind of on a bit of a kind of fight to change that terminology. And I've written there, it's all about chopped tomatoes. If we have a little look through these slides, there's Sainsbury's chopped tomatoes, Sainsbury's basics chopped tomatoes. Now that to me doesn't look very appealing. It looks bland. It looks kind of, not very healthy. It doesn't look very interesting. It doesn't make me kind of think, that looks like something I want to buy. If we move on, Waitrose have got it right. They've called it essentials. It's essential chopped tomatoes. That's color involved. It's enriched natural juice. It's all the things that you want from a product. Now, if we think about a medical side of it, if you think of basic life support, CPR, again, that, you go and do a first aid course, and first aid at work courses, they're better now than they used to be. However, they often were deemed to be a necessary evil, and people would trudge along to these courses and they'd immediately switch off because it was all termed as basic. And I implore you, when you do your next course, be that in whatever remit it is, think about the word basic and maybe change it to essentials. I've actually got a meeting with the Resus Council when COVID ends about terminology and about, who knows, maybe BLS, basic life support, ends up changing to ELS, and you'll have heard it here first. So we'll see. Waitrose is expensive. I don't shop at Waitrose, but, I do shop at Aldi. And they have got it right. So it does show that, you don't have to be the high-end product to have the good terminology. That tells you everything you need to know. It's a nice tin of chopped tomatoes. It's got the color. It shows you it's healthy, but it says essential. So we're going to talk about medical essentials. We're going to talk about the essentials of a lot of different things over the next hour. So what is the worry with stand-up paddleboarding? It is a really safe sport. It is a fantastic sport, fantastic fitness. There's so many different variables involved in it. You know, you've got racing, you've got leisure, you've got touring, you've got downwinding, you've got white water. And with those different variables come some dangers. You know, you're probably thinking that, you know, I'm a flat water paddler and I'm not going to cause myself any injury or cause myself any illness by doing it. And that may be true. And you'll go through your whole stand-up paddleboarding life without any issues at all. And you won't have any worries. However, things do happen. And I'm going to talk about 3 different topics and break those down a little bit further. I'm going to talk about some medical things that could occur when you're on the water. I'm going to sort of talk about some trauma, so some injuries that you could sustain, and I'm going to touch on some environmental issues as well at the end. So as Chris said, ask any questions as we go, and we'll see what we come across. So we'll dive straight into it. These are the ones that we're going to cover from a medical side. So asthma, seizures, diabetes, anaphylaxis, chest pain, and I'm going to add on a little bit about cardiac arrest as well there. So we're going to talk about, first of all, asthma. You'll see I've gone kind of all in these GIFs. So these GIFs are all the way through the presentation. There are no gory pictures. There's one of a bleed later on, but it's very minimal. So hopefully you won't be squeamish and have to turn off. But with regards to asthma, now you might not have asthma, but somebody you're paddling with may have asthma. Now I implore you to find out the medical history of those people that you're paddling with. Ideally, you know, we always say that you should paddle as a group or paddle as a pair for safety reasons, obviously. It may be a case that you are on a trip abroad and you don't know that the person paddling with you has asthma and they're exerting themselves, they're pushing their limits a little bit more, they're training hard, and they suffer an asthma attack. So we're going to talk a little bit about asthma now. So what is asthma? Asthma is a narrowing of the airways. Now, what happens with regards to asthma is they build up a large amount of mucus and it plugs those airways, and an asthmatic patient doesn't have problems breathing in so much, but breathing out. You may have seen, I'm sure you'll have seen it on TV when somebody has an asthma attack, they really struggle to get rid of that huge amount of gas that's building up inside their chest, and asthma can kill. It's rare that it kills, but it can kill. It's a serious medical condition. Now, normally asthmatics, they have their medications, they have their inhalers. Again, if you go paddling and you're going paddling a long distance, make sure that you have your inhalers, your medication with you, and likewise check on your paddle partner and make sure they have theirs if they need it as well. If you're with somebody and they are suffering an asthma attack, what do you do? What are the essentials? You'll see that written at the bottom of all the slides. What are the essentials? What are you going to do? First of all, you're going to ask them if they can get to the side of the water, be it on the riverbank or on the estuary, or if you're paddling in surf, then get them back to the beach as quickly as possible. Now, hopefully, when you're paddling, you'll have realized and noted that the person having the asthma attack is struggling. So they shouldn't, and I'm pretty certain won't develop an asthma attack, which is going to be life-threatening in a really quick manner. It's going to come on progressively and it's going to worsen with time. So as soon as you realize that they are suffering with an asthma attack, get them to a safe location. That's one of the first things. We always, again, say that you should have communication devices with you. You know, with all of these medical conditions, it's getting help early that's going to assist that patient. So make sure that you're ringing 999, requesting an ambulance. And again, through all of this, know your location. You know your location, make sure that you are aware of where you are at all times, because one of the first questions that gets asked when somebody rings 999 is, where are you? If you're not sure, then there are methods of finding out your location. What 3 words is fantastic. So when you get on land, basically the whole of the UK is mapped into a 3 foot by 3 foot square. And you can download this app and it will give you 3 words. You can pass that over to the emergency services and they'll know exactly where you are. You know, it's pointless telling the person at the end of the line what's going on with the patient if they don't know where to send help. So you've got to land, you've got your patient there who's having an asthma attack. It all comes down to the simple things, the essential stuff. Stop the patient from exerting themselves, calm them down. If they have their inhalers with them, then assist them to take their medication, okay? So assist them to take their inhaler. Now, I'm sure they'll be able to take it themselves, but if needed, assist if you can. You know, asthma does relieve itself after time and after rest, unless it progresses further. And just make sure that you're sitting them down. Don't lie the patient down, have them in a sitting position. Basically, if you imagine yourself and your lungs are working hard, if you lie down, so you're flat on your back, your lungs are working harder. We're not as a species designed to be lying down. So have them in a sitting position so the lungs are in the positions that they're best going to function, and lean them forward. You know, sit them in a kind of position where their elbows are on their knees, sitting forward. That will open up the chest space and that will allow them to breathe easier. Try and get them to slow their breathing down if you can. This might require a little bit of coaching. Now, on the flip side of asthma, you've also got something called hyperventilation, which patients who have anxiety kind of suffer with quite often. That isn't asthma. That isn't a narrowing of the airways. They're not building up that mucus. What they're doing with that hyperventilation is they're taking on too much oxygen. Now, that can be bad as well. And that is something that definitely requires coaching. So what you need to do is make sure that the patient is breathing at the same rate that you are. So what I normally do if I come across a patient who's hyperventilating is ask them to take a breath in and then hold their breath. Hold their breath for the same time that you do, and then allow them to exhale. And keep doing that. And this can take 5, 10, 15, 20 minutes to take effect. The only person who's going to help them to slow their breathing down is themselves. So the coaching is absolutely vital with regards to hyperventilating. So asthma, just to recap, get them to land, make sure they're in a safe location, make sure they've stopped exerting themselves, get their medication on board if you can, assist them to take their medication, and get help. As I said, it will revert itself with time as long as they get their medication as early as possible. Now, back in the day when I was teaching lifeguarding, I'd often get asked, can you use somebody else's inhaler to treat a patient if they haven't got their own? I would say, personally, if I had a patient who was having an asthma attack and somebody said, here's a salbutamol inhaler, which is the drug that's inside that inhaler, I would use it. Now, I can't advocate that. And please, if anything happens, then don't say, well, I saw a webinar once and Gordon Ingram said I could. But, you know, it may be the best care that you can give that patient at that time. So moving on, seizures. So I haven't labeled this slide as epilepsy. Now, seizures can come on for a number of reasons. Seizures can be caused by epilepsy, but there are a number of others that can cause seizures too. So I'm just going to call this as a kind of an umbrella label as seizures. If you come across a patient who is having a seizure, it's very distressing to see if you haven't seen one before. It's very unnerving. And obviously, if you're in the water, it's very dangerous. Now, it's a difficult thing to deal with when you're in a water environment. Luckily, if you're paddleboarding, you have an 11-foot, 12-foot, whatever size, big inflatable or rigid device to get your patient on. So I would suggest if you're in deep water, paddling out in a lake or in the ocean, then get your patient on a board and tread water next to them with your arms over the board, keeping them, not restraining them, but your arm over them so they're not going to roll off the sides, and allow the seizure to happen. Now, back in the day, it used to be you'd put a wooden spoon in the mouth or you would restrain the patient. Now we allow the seizure to happen and then we see what occurs later on. There is no medication in a first aid environment that you would probably have to your hand to assist with the seizure. It's all about allowing that patient to have the seizure. and seeing what occurs later. With regards to seizures in the water, if they're physically in the water, getting them onto that board is what's going to, keep them safe. The most important thing with a seizure is the airway. If they're in the water, as I said, get them out, keep the head above the water as best you can. These are all techniques taught on lifeguarding courses. But if they're on a board, they're nice and safe. That seizure, if the patient suffers with regular seizures, will pass with time. Now, what happens after a seizure is a patient ends up in what we call a post-ictal state. They will be tired. They will be shattered. You may have the unfortunate event where a person comes up to you and says, I'm about to have a seizure. I know I've had that lifeguarding back in the day. And somebody came up to me, they said, I'm about to have a seizure. I am epileptic. And they get what we call an aura. They get a funny sensation in their nostrils, a funny smell, or they may see stars or lights. They may see flashing lights in their eyes, and they know that this is going to happen. If that ever happens to you, be aware of it. Make sure you get your patient in a safe location. Make sure they're not going to cause any injuries to themselves, their head. Make sure it's all safe around them. Loosen any tight clothing around their neck and allow the seizure to happen, as I said. Obviously, keep bystanders away if you can, if you're on land. People will come and offer help, but what you don't want is a massive group of people watching this person having a seizure. I'm sure none of us would like that. They may lose bladder and bowel control. So try and keep them in a confined space, away from people just watching for whatever reason. We are a strange group of people when they do that. With regards to medical assistance, should you call an ambulance if somebody's having a seizure? I would suggest that if they are known to suffer seizures regularly and they normally take medication and for whatever reason they've had a seizure, if the seizure ends and they become back to their normal self, then it may be a case that they don't need to go to hospital. However, what I would suggest is you still call 999. You get medical assistance to come to assess the patient professionally and then make a judgment call on that manner. Allow the paramedics to make that decision for you. Take the onus away from yourself. If somebody's having a seizure and they've never had a seizure before, or they've caused injury to themselves, then of course you want to be calling 999. And if somebody's had a seizure and they've been submerged in the water, again, of course you're going to be calling 999 to make sure the patient has the full assessment that they require from the ambulance service and treatment at hospital, transportation to hospital for ongoing assessment as required. So with seizures, just to recap, keep their airway above the water, keep them on the paddleboard or a flotation device of any sort that you have to hand. Allow the seizure to happen. If they're in a wetsuit, you may want to loosen it when you get to land, obviously not in the water. It's going to become very cold very quickly. And make sure that they don't suffer any trauma, any injuries to themselves when they have the seizure. But 9 times out of 10, the seizure will revert with time. But just remember that state that they end up in. They end up in a post-ictal state where they become very drowsy. They're not aware of what's going on. They are unaware that they've had a seizure. But again, as I said, that does revert. Diabetes. So that's a great gift, this one. I like this one. What is diabetes? Diabetes is an imbalance of sugar in our body. Now, there are 2 different levels of sugar. You can have something called hypoglycemia and something called hyperglycemia. I'm not going to go into massive depth as to what they are, but I will touch on them and kind of cover the one that you're more likely to come across. So hyperglycemia is where your blood sugar level has gone too high. Now, this takes hours and days to have an effect normally. Diabetics will generally know that they are diabetic. They'll be on tablets, or it'll be diet controlled, or it may be insulin controlled through injection to make sure that their normal sugar range remains in a safe parameters. So hyperglycemia, you're unlikely to come across if you're paddling. However, again, it's about getting to land. It's about getting ambulance service to come and assist you and getting your patient off to hospital where they can have advanced medical care to revert their blood sugar level back to the realms of normal. Hypoglycemia, on the flip side, is low blood sugar. Now, this may be one that you come across. If somebody hasn't, I've been there. If somebody hasn't eaten all day, they are, people tell me I get hangry, I get hungry and angry, I get irritable. I'm not diabetic, but we'll have all suffered symptoms like this when we haven't eaten well. We may have exerted ourselves, done some physical exercise, and we just feel really miffed and feel really lethargic. So that may be a case where your blood sugar level has gone too low. Now, normally that can be controlled by diet. You feel hungry, you feel tired, have some food, and it reverts itself, and you can carry on as normal. With a diabetic patient, if their blood sugar level drops too low, then they will become hungry, they will become tired, they will become irritable, they will become confused. They'll almost appear drunk. So what we need to do with those patients is get them some sugar, So it's the simple things. I was almost about to say basics. It's the essential things that this patient needs. It's getting sugar into them. Now, I'm sure it's common sense. How can you get sugar into a patient? So through food and drink, quite quickly, quite easily. As long as the patient still has the conscious level to eat or drink, then give them something to eat or drink. Make sure in your pack, if you're paddling a long distance for a long time out on the water all day, you have some sugary, some rehydration sachets, some sugary food, some chocolate, whatever it may be. And share that out. Don't eat it all yourself. Make sure you give it to the patient and try and get their sugars back to normal. What else? I was about to mention something else on diabetes there. What was it? It was...
I could chip in, Gordon.
Go for it.
Yeah, just a quick question. You said if they're conscious and they're able to digest a sugar substance, what would you do if it deteriorated rapidly and the casualty became unconscious? I think I know what you're going to say, but just for our...
Okay, so it will be, so if your casualty has deteriorated and they're diabetic, so that they're diabetic, that they've got that medical condition, and you think they're hypoglycemic, so their blood sugar level has dropped considerably, then you want to get them in the recovery position. That's one of the first things you want to do. Make sure their airway remains clear if they vomit. So get them on the side. The recovery position is very simple. It's basically on your side in a position where if you do vomit, then it can drain from your airway nice and easily. And obviously, we don't want to be shoving food or drink into a patient's airway when they are not conscious. That would be bad. However, the sugary gels, the sugary gels that you can get a little bit of that on your finger and rub it into the gums of the patient, and that will get absorbed into the bloodstream, and that may revert the blood sugar level back to the realms of normality. It is about getting at that level when they've become semi-conscious to unconscious because of it. It's about getting medical assistance to come, and then we can insert a drip into the patient's body and deliver intravenous glucose and raise their blood sugar medically. So that was probably the best thing to do. But it's all about monitoring your patient. Again, it's tricky when you're out on the water to get them back. So, as Chris said right at the start, there are courses out there that will teach you techniques of getting your patient, your friend, your colleague, whoever it may be that you're paddling with, back to land safely in the best method possible. Does that cover your answer, Chris?
Yeah, it does. I think underlying a lot of this stuff is the essential need to have some form of communication device when we're out on the water.
Absolutely.
Whether that be a mobile phone in an aquapack case, or if you want to take it to the next level, a VHF radio. Yeah,
for sure. I've done big paddles with you out to Gullen before, Chris, and I know that we always had a radio with us and a phone, I think. So yeah, definitely worthwhile having. Okay. So, happy, Chris? Yeah, okay. Moving on. So moving on, anaphylaxis.
Actually, hang on. We have got a question from Gavin and saying, so tubes of glucose type products to rub in the gums. That's what you mentioned, didn't you?
Yeah, absolutely. So it's called HypoStop is the trade name. So they're great. You can just have a couple of them in your pack. and that works really well. It's a really sugary gel that you can just put on the patient's gums, and it'll get absorbed, as I said.
Excellent, thank you.
So moving on to anaphylaxis. Anaphylaxis, what is it? It's a massive allergic reaction. Now, people can be allergic to anything at any point in their life, and allergies can come and go through your life. Allergies can range from a small itch to hives to airway occlusion. So with regards to anaphylaxis, what happens is you get a release of histamine. Now, histamine is a chemical that's produced by the body when an allergic reaction occurs. And what happens with that is you get swelling, you get hives, you get, what happens is all your blood vessels get bigger. And because your blood vessels get bigger, your blood pressure drops. If you imagine a vein or an artery and it increases in diameter, the pressure in that system is going to drop. You get a lot of swelling. So our biggest concern with regards to anaphylaxis is the airway. I keep focusing on the airway because it's one of the most vital components. What we don't want to happen is, somebody's tongue to start swelling and blocking their airway. Now, again, it's knowledge of your colleagues and people that you're paddling with. Try and find out if you can, hopefully you're paddling with people you know well, and you know that they may have allergies. Now, what could you be allergic to out when you're paddling? Bees, wasps, jellyfish, weaverfish, all these things are out there. And, if you come into contact with them and you suffer allergies, then it may be a case that you suffer with anaphylaxis. Now, a lot of patients who suffer with allergies, a regular occurrence, they carry their own Epipens, which is a small mini jet, which has adrenaline in it. And what adrenaline does is those blood vessels that have dilated that I mentioned before, that constricts them back to normal. And it reduces the swelling and the edema around the body. And obviously, if we've got swelling and edema to the airway, then that'll make that back to normal. So again, it's getting them to land. It's getting them to land as quickly as possible, as safely as possible, and monitoring your patient. Getting them into the recovery position so that airway remains clear. So if they do vomit, then it goes away from the patient's airway as easily as possible. Something I haven't mentioned on, but it is quite essential, is if you get to the patient to land, make sure that let's say you're on a beach, make sure you take that patient far enough up the beach that they're away from the tide, which is going to be a big danger. If things go south quickly and the tide's coming in, what you don't want to do is have to keep moving your patient all the time. So move them to the safest location possible as quickly as possible. With regards to all of these things, we want to try and cover something called the primary survey. I'll cover it at the end, but one of the first things on the primary survey is the airway, and we just want to make sure that remains clear at all times. If they have got an EpiPen, it's very easy to administer. As I said, it's just a mini jet with a needle on one end, which is capped, and on the other end is a plunger, normally a red button. So you administer that very simply by administering into a large muscle mass on the patient's body. So try and take the wetsuit off the shoulder and administer it through there, or if they're just wearing shorts, administer it through the buttock. Put the mini jet onto the skin, press the plunger, the needle protrudes out the end, and then it introduces the adrenaline into the bloodstream. Hold it in place for about 10 seconds, and then massage the area slowly so it gets in the bloodstream, gets absorbed, and has the effect that's required. Again, as I mentioned with asthma, somebody's suffering with anaphylaxis, and they're getting swelling in their airways, and somebody else has an EpiPen on the beach or wherever you're paddling, then administer it. It is a life-saving drug that can be administered by anyone. You do not need training to deliver an EpiPen. So it's very safe. I've seen it go wrong once where somebody had the EpiPen the wrong way around and got a nice shot of adrenaline into their thumb. So make sure you're holding it right. There's instructions on the side of the mini jet, and that's the thing that's gonna save a life.
I've got a quick question for you.
Yeah.
Could a bystander's EpiPen be used in an emergency? Absolutely.
So as I said, it's a life-saving drug. If somebody was in front of me having anaphylaxis and I wasn't medically qualified, I would still administer that anaphylactic shot, that adrenaline shot into the muscular mass of the patient. So yeah, absolutely.
Okay, thanks.
It's what we call a Schedule 7 drug, I think. which is something that can be administered by anyone to anyone in the event of a life-threatening emergency.
And just for the benefit of the audience, does that needle penetrate through a summer 3mm wetsuit? Or
I knew you were going to ask that question, Chris, and I don't know the answer. That's why I said I'd take it off the shoulder.
Okay.
I imagine it would. You know, they're quite long needles. However, if you get the wetsuit off the shoulder, you're going to know that it's definitely in the right place. The last thing you want is to put it on the wetsuit, administer it, think that it's gone in, and it's actually just been absorbed into the neoprene of the wetsuit. So I would expose the skin that you're going to be putting the shot into and make sure it's in and doing its job as it needed.
And we're doing the parachute jump, 1,000, 2,000, 3,000, up to 10.
Yeah, hold it on there for 10 seconds, massage the area, and allow it to get absorbed into the bloodstream.
Okay, thank you.
No worries. Moving on.
Yeah, we had a little bit of an issue with the sound. I don't know if that was your end, our end, but it seems all good now.
Okay, fine. Chest pain. So this could be one of two reasons really why somebody has chest pain when they're out exerting themselves on the water. Hopefully, you know that again, it's knowledge of the people you're paddling with. I keep going back to that. Hopefully, you know if somebody has cardiac issues and know that their medical history with regards to that. So chest pain can be basically caused by a number of reasons, but if it's something to do with the heart, it's basically you've got the coronary arteries which supply the heart with oxygenated blood. And it's a buildup of fatty tissue in those coronary arteries. Now, what happens is we all have that fatty tissue building up from the first time we ate a packet of crisps when we were a kid to all the stuff that we eat and drink and whatever we do through life. Exercise obviously breaks those fatty tissues down. But if those fatty tissues build up so much in the coronary arteries and you develop a blood clot, that gets blocked by the buildup of the fatty tissues on the wall of the coronary vessels, and then that'll slow or stop the blood flow past that point, which causes obviously an effect on the heart. Now, if somebody is having chest pain and they're out on the water doing physical exercise, and then they stop doing the physical exercise because they've had chest pain and the chest pain recedes and stops, then it may be something called angina. Now, angina is something that it is a narrowing of the arteries, and it is something that can be treated very simply, needs to be referred to hospital. And there are many, many patients out there who suffer angina and still participate in exercise all through their lives. If the chest pain has come on at rest or it hasn't dissipated with rest, then they may be having a heart attack, or what we call in the medical world a myocardial infarction. The myocardium is the muscular layer of the heart, and infarction means death of. So basically, it is a full blockage of one of those arteries, causing ischemia or death to the part of the heart past to that point. Now, that might feel like a tight band around their chest. They'll be able to pinpoint the pain. If they ask them where the pain is and they're saying it's there, then it could be a sign that they're having a heart attack. With regards to that, I would say, sorry, apologies, I've got that the wrong way around. We all make mistakes. If they're having a pinpoint pain, it's possibly not a heart attack. If it feels like it's a tight band around the chest, it may be. Apologies. So they are feeling worried, they are pale, they are struggling, they are looking like they're not going to do very well. And there is a bit of text in every first aid manual out there that says they will get a feeling of impending doom, in inverted commas. And I tell you the truth right now, I once had a patient who was having a heart attack, and I said, "How do you feel?" And they said, "I have a feeling of impending doom," verbatim from the first aid manual, and he was having a huge heart attack. So what are we going to do about that? Again, it's stopping the activity, it's making the patient rest, it's putting them in the most comfortable position for them. Now, again, a lot of first aid manuals will say out there that they need to be in what we call a W position, which is where your back's up, you're leaning forward, you've got your elbows on your knees again, to decrease the stress on the heart. What I would say with all of these things, be it trauma, be it medical, if the patient is in a comfortable position and they are comfortable and safe, then leave them in that position. It's going to be best, you know. Think of it, I'll come on to it later, but a dislocation. If they're holding their arm, if they've dislocated their shoulder or one of the bones in their arm and they are in a comfortable position, then leave them in that position. Just because a first aid manual said that they need to be in a certain position to put a sling on or to get it immobilized as best as possible, if that's going to cause trauma and pain by moving and manipulating the hand or the arm into a certain position because a manual says so, if they're holding their arm or their wrist and it's in a nice, safe, comfy position, leave them there. There's no reason to. Get medical help and, you know, they will make the full assessment.
Gordon, quick question come in. Heart attack, difference between men and women's symptoms? Are there any?
No, same.
Same, okay.
Yeah. Good question. All right. Moving on. Sorry, let's go back one. Chest pain. You may have patients who have medication for this. So you may have a patient who has a little spray that goes underneath the tongue. That's called glycerol trinitrate. And what that does is, I mentioned chest pain. What is it? What's the cause? It's a furring of the arteries and a blockage. What GTN, glycerol trinitrate, does is it makes the vessel bigger. So it allows the blood flow past that point of occlusion, of the blockage. So you might have a patient who has GTN in their pack. And again, it's a spray that's underneath the tongue, and we just give 2 little sprays, and that dilates the vessels, makes them bigger, and allows the blood flow past that point. They may also have aspirin. Aspirin is a life-saving drug. It's one of the drugs that we give as paramedics, as critical care teams. We give it as early as possible because what aspirin does is thins the blood. So if you imagine you give the aspirin and they can just chew it if they can't swallow it, give the aspirin, that thins the blood down. And if they also have GTN, that increases the size of the vessel. Both of those things working well together to increase that blood flow past the point in the blockage to give the heart the blood flow that it requires. So that's the treatments.
Gordy, can the GTN spray be administered more than once? And if so, what kind of time scale?
So I would only give GTN twice. So 2 sprays at the same time underneath the tongue, because what you don't want to do and what you don't have in a first aid scenario is the method of taking a blood pressure. So obviously if the patient is in pain and you give the spray underneath the tongue, you've made that vessel bigger. And if you make that vessel bigger, the pressure inside that vessel drops. And if that pressure drops so much and you give another spray, it makes the vessel bigger again and the blood pressure drops more. So only give it one time, 2 sprays is what I would recommend.
Okay, and then just sorry to take you off track, but just back to EpiPens while the questions are coming in.
Yeah.
Questions is this EpiPen something that we could keep in our first aid kits if we're leading groups, just in case someone had an anaphylactic reaction? Can they be bought in a chemist online?
No, I don't think they can. It's not an over-the-counter medication. No. So it's not an OTC, which is like aspirin or paracetamol. It is a prescribed medication to patients who are known allergies, I think. And I don't think you would be able to carry it because it's, you wouldn't be able to carry it because it's prescribed. However, you can administer it in a life-saving emergency.
Okay, thanks for that.
No worries. I'm sure there's medical professionals also watching this and they're typing in at the same time. So if any of my colleagues are out there and I've got that slightly wrong, please let me know. All right. Cardiac arrest. This is obviously bad. This is obviously where we've found out that our patient is not breathing. Now, one of the first questions, again, when you call 999 is the patient breathing normally? Now, they've added that word normally onto the question. And the reason for that is some patients, when they go into cardiac arrest, now cardiac arrest is where the heart stops. Some patients, when they go into cardiac arrest, they suffer what we call agonal respirations. Now, agonal respirations is like the last breath. It's the body trying to increase pressure on the heart and keep it pumping. Now, why do we do CPR, cardiopulmonary resuscitation? Why do we jump up and down on a patient's chest and breathe into their mouth or nose? Now, a lot of places say that we are doing that to keep blood circulating around the body. That's one reason. One of the other reasons we do CPR is to keep the blood flow to the heart and to keep the electrical activity to the heart. Now, the heart works by an electric, not to go too deep here, but the heart works by electricity, in inverted commas, and it fibrillates, it goes boom, 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 and there's an electrical signal that makes that happen. Now, if somebody suffers a cardiac arrest, at the top of the heart, you've got the atria, and at the bottom of the heart, you've got the ventricles. When they go into cardiac arrest, they can go into a number of different rhythms. One of the rhythms they can go into is called ventricular fibrillation. So the ventricles are at the bottom, so that's my left hand. And what that does is it kind of goes like jelly, okay? It's fibrillating, okay? It's like jelly. But that's good. That's good if you're in cardiac arrest, because what there is electricity. There is stuff going on, and we can do something about that stuff. Now, when you're in cardiac arrest, to get somebody out of cardiac arrest, CPR doesn't revert it. It's the defibrillation that reverts it. It's the administration of an electrical shock to the heart that shocks that fibrillating heart back into a normal ba-boom, ba-boom, ba-boom rhythm, okay? So if somebody's in ventricular fibrillation where the heart's doing this, that's a good thing. Now, by doing compressions on the patient's chest, what we're doing is keeping the activity there, the electrical activity in the heart. And what we're doing is biding ourselves time. So we keep jumping up and down on the chest at a rate of 100 to 120 a minute, so it's nearly 2 a second, and we're squeezing that chest cavity 1/3 of its depth. Now that's from front to back. We never worry if we're going too deep, because we're squeezing that heart between the chest wall and the spine, and we're keeping that electrical activity going. The quicker we get a defibrillator onto that patient, that increases the chance of their survival. If the patient isn't given CPR when they're in ventricular fibrillation, or when they're in any rhythm where they're not breathing normally, then what will happen with time is that electrical movement will just slowly and gradually dissipate to nothing. And we'll have all seen medical dramas where it's just a flat line. And what I want you to do is not believe the medical dramas when it's a flat line and they get delivered a shock and suddenly they wake up and they're having a cup of tea. That doesn't happen. You need to have some electrical activity within the heart to provide a shock to. Now, there are automated external defibrillators everywhere. They're in shopping malls, they're in cinemas, they're in supermarkets, they're on beaches. All the lifeguards have AEDs on the beaches, and there are public access defibrillators everywhere, and there's more and more getting put out there, which is fantastic. So if you're paddling in an area where there is an AED, the ambulance service that you call will know that. They will direct you or be able to direct somebody to go and get the public access defibrillator from a box, which may be on a town hall or a side of a shop, and get back to the patient as quickly as they can. What I would say is, don't you go and do it if there is somebody else who can. You need to be doing the chest compressions. Keep jumping up and down, pushing up and down on that chest, 30 compressions, and then we're going to give 2 breaths. Drowning, we're going to talk about a little bit later, but this is if somebody's had a medical event, which is called a cardiac arrest, where they've stopped breathing or they're not breathing normally. 30 compressions and 2 breaths. And I'm going to talk about how we give those breaths a little bit later on. It's a life-saving skill. It's not difficult. I'm not going to go into the finer points of how to do it. If you have to do it and you ring 999, they will teach you over the phone how to provide CPR. And it is really, really clever, the terminology they use to make people who've never had any training to deliver good quality CPR. And the word that I'm going to focus on there is quality. So the better quality the CPR is, the more chance of survival of that patient. If the patient doesn't have CPR for a prolonged period of time, obviously that electrical activity is going to dissipate and it's going to become nothing. And then the defibrillator won't provide a shock to the patient. the defibrillator has to pick up some electrical activity for you to be able to press that shock button. If it says that there's no shock advised when you put a defibrillator on, then it will ask you just to keep going with compressions to see if we can get some of that electrical activity back to the patient before you press shock.
Gordon, just a quick question. Bearing in mind that our audience are predominantly paddleboarders, I would suggest, and water and electricity, do they mix? What are some guidelines for placing a defib on a casualty who's wet?
So
jewelry or the pacemaker.
So if you've got a patient out in the water, in deep water, and they're in cardiac arrest, get them to land quickly. That's for two reasons. You are not going to be able to do good quality CPR on a paddleboard. There is too much movement, so you're not going to have that effect. You know, I've been to a number of countless casualties where they've been on the bed and they haven't been put on the floor. And CPR on a bed would be the same as CPR on a paddleboard. It wouldn't work. So get them to land where there is going to be resistance on the back of the patient, so your chest compressions are going to be effective. Dry them off as much as you can, cut the wetsuit off if you can, and then expose the skin. If you've got anything that you can just towel dry the patient off with, that's great. You don't want the patient soaking wet at all, but you know, if there's small residual water in the area, that's fine. You know, I used to be on the lifeboat crew, and I would have a AED in the boathouse, in the wheelhouse on the big all-weather lifeboats, and I've used them in, you know, rainy situations, stormy situations on the back of the lifeboat, and it's been safe. The electrical activity goes from one pad to the other through the heart, okay, through the direction of the heart, and it's just going to go from pad to pad. You would have to be very, very unfortunate to have any arcing of electricity unless the patient is soaking wet. So use whatever you can, you know, take a t-shirt, take a towel out, whatever it may be, grab somebody off the beach, grab their jacket, dry them off as best you can. If there's a pacemaker scar on the upper left side of the patient, then, you know, make sure the pad is far enough away from that. It's not going over the pacemaker scar, but it needs to be about 3 to 4 centimeters down on the side of the patient's chest, over their pectoral muscle and the side of them, and that will be safe. Any jewelry that they've got around, try and take that off, just reducing the risk of the electricity arcing.
Okay, that's great. And just getting a few comments about rescue breaths and administering them. Just, I think it's probably quite pertinent to point out that under the current COVID guidelines, as a lay person, or even if you're basically first aid trained, the current guidelines, we are not to be giving rescue breaths. That's to be pretty much left to the paramedics with their BV bag valve mask. I would suggest, Gordon, that's your
correct
bag. Excuse the pun. So if you are unfortunate to face any type of cardiac incident, then the current guidelines say just first of all, make sure you've dialed 999, then start working on the chest once you've got someone to a rigid ground area.
Absolutely. The emphasis is on the chest compressions, not the breaths. That changes slightly with drowning, which I'll go over later on. But with regards to a medical event, which is caused a cardiac arrest, the emphasis is on the chest compressions. Keep that electrical activity going in the heart, which is going to increase the chances of the defibrillator working. Yeah, and
even though if we are trained, we are at the minute not to be given the rescue breaths. Okay, correct. I hope that's cleared up that for people. Thanks.
No worries. Okay, so moving off medical onto trauma. We're going to cover these topics here. So sprains, strains, dislocations, fractures, open wounds, head injuries, and spinal injuries. So sprains and strains, something that you may well come across. You know, you're exerting yourself, you're paddling, you get a pulled hamstring, you get a pulled muscle in your arm. You know, not something that's going to cause major problems right away unless you are in a completely isolated environment a long way from land. However, you know, if you're in the vicinity of land, you can always get yourself back to land, or your paddle, the guy or girl who you're paddling with can get you back to land. And, you know, it's all about stretching pre the event, making sure that you've warmed up, making sure that your muscles are aware that you're going to be doing some exercise. And then if you have had the misfortune of pulling a muscle, then it's all about rest, utilizing ice. This is all still in the NHS guidelines. Rest, ice, compression is still in there, but I wouldn't emphasize that too much, and elevation. And it's utilizing some over-the-counter medication. So paracetamol is a great analgesia. We use that both orally and intravenously for a lot of our patients. So paracetamol is fantastic, and ibuprofen, which reduces swelling. So both of those work well together, and they both have different effects on a muscle and will relieve the tension and relieve the strain on that affected muscle. I'm going to throw this back to Chris, because I remember many, many years ago, Chris decided, she went surfing and pulled your hamstring, am I right? And it was really bad.
That's right. And it was one that led to bruising from the buttock to pretty much to the calf muscle.
Yeah, I remember that. Yeah.
Not ideal for driving Series 3 Land Rovers with brakes that don't work and you've got to press hard on the pedal. That
was fine. You know, so it is debilitating. They're an awful injury to have, and the time it takes to get back from just a small, I say small, you know, from an injury like that, it's a long time. So prevention is better than cure for these types of injuries. Okay. Moving on. Yeah, hang on. I'm gonna go back. The next video does make a lot of people squeamish a little bit. I'm gonna keep it, letting it go. But you know, it is something that we could come across paddling, surfing, enjoying being out on the water. But there's my my caveat. So we'll move on. There we go. So dislocations and fractures. Okay, you're paddling, you fall off, and your ankle does that. Ouch. Dislocations and fractures. So an affected limb or affected joint which has been dislocated. What are we going to do about those? Again, it's all about getting back to land as best you can, as safely as can. So, you know, if you're out, you know, paddleboarding in surf, this is going to be painful. This is going to hurt getting back to land, because you're going to be bashed by waves. You've got a big paddleboard and a paddle in your hand. It's going to be difficult. So you're going to require assistance to get back to land. It's not going to be nice. It's not going to be pretty. It's going to hurt. When you get that patient back to land, what are the essential things that we need to do? We need to make sure that the patient remains as still and as immobilized as possible. Now, when you get back to I'm going to take the instance of being on a beach, because that's kind of where I grew up. When you get back to the beach, again, as I said, make sure the patient gets away from the main danger on the beach, and that's the tide. What you don't want to do is move the patient more than once. You have a stretcher available if you're paddleboarding. It's, you know, my paddleboard is 12'6" long. You can put a patient on there, get some people on either end, and get them as far up past the high tide line as possible. Then they're in the safest place. With minimal effort, minimal movement, you can get them onto a board, you can get them up the beach, and then you can start treating treating in inverted commas the dislocation or the fracture. Now, a dislocation is where a bone has come out of a joint. I implore you not to try and put any dislocations back in at all. Even if somebody says, oh, my shoulder pops out all the time, I'm just going to put it back. You know, all I need to do is this, and they know a certain technique. Don't. Make sure you get medical assistance to come and fully assess the patient. What you don't want to be doing is trapping nerves or vessels into that joint and causing unforeseen damage. So with a dislocation, what are you going to do? You're going to immobilize the patient. Now, wetsuits are fantastic because you've almost got kind of a material that's going to hold the limb in place and almost immobilize itself. If they're not wearing a wetsuit, let's say they dislocate their ankle and you've got them on the beach, utilize what is around you. You're on a beach where with lots of sand, and sand moves. You can pack that sand around the dislocated limb, and that'll stop them moving it, okay? Just be aware that it may get cold after time. So utilize the sand, you know, pack it around the limb, keep it as safe as possible. With regards to fractures, what the worst case scenario is a fracture that is protruding out of the skin of the patient, because then you've also got the risk of infection and movement of the bone. If a fracture has happened and it's closed, it's what we call the closed fracture, where it hasn't protruded out the skin, you may see a lot of swelling. The patient will be in a lot of pain. Now, one of the worst fractures, or one of the big fractures that you can get, is a fractured femur. So that's your thigh bone. Now, you can lose a third of your blood volume into one thigh cavity, and that is a life-threatening injury. So you would get assistance on the phone, on the radio, whatever it may be, when you call 999 and how to treat that. But it is all about immobilization. It's all about keeping the patient in as comfortable position as possible. If there is a bone protruding through the skin, it's all about keeping it as clean as possible. Have bottled water with you. Don't try and debride. Don't try and get rid of any small bits of sand or gravel or whatever it may be that's in the site of the open wound. Just clean it with some water as best you can, and then keep it covered. Try and stop infection getting in there. With regards to fractured ankles like this chap has got, don't take the shoe off. Let the medical professionals do that. The shoe is going to encase the foot, or if it's a wetsuit boot, same theory. Don't take the wetsuit boot off to have a little look, because what that's going to do is take rid of a lot of support from that ankle, from the back of the heel, from the foot, and it could move and have some, it would be bad. So just keep the wetsuit boot on, keep the shoe on, whatever they're wearing, and just keep them as still as possible. Pain relief is going to be needed, and the best form of first aid pain relief is immobilization. You can ask a question, Chris.
Yes. Paracetamol and ibuprofen. Can they be administered in what kind of time span? Okay, so gosh, let me think. First aid, paracetamol. So it's written on the box. There's my first caveat. It should be written on the box, and you shouldn't be carrying drugs or paracetamol or ibuprofen without being in the box. So you can refer back to it. Paracetamol is a maximum dose of 1 gram in a 24-hour period. No, it's not. Paracetamol is 4 grams in a 24-hour period, given in 1 gram doses, which is normally 2 tablets 4 times a day. Ibuprofen, I can't remember the maximum dose of a day, but it's 400 milligrams normally, and you would give that every 4 hours as well. But you would back-to-back them. So you give paracetamol and ibuprofen, then paracetamol and ibuprofen, and leapfrog them through the day. Okay. That wasn't me trying to catch you out there, Gordon, but I just think it's an important question. It's an important question that has come through. Yeah, it is. Just mindful of our audience, just if anyone does have to go, this will be recorded, just to remind you of that. But it's going really well, Gordy, so keep going, my friend. I don't know how much longer you've got in your presentation, but it's very interesting. It's 9:05 already. Time flies. Yeah, all right. Just a subtle way of telling you that it's 5 past. Hurry up. Whistle stop 2 is going to get a lot quicker. All right. Open wounds. What we're going to do, we're going to put something over it, and we're going to stop the bleed. There is some blood in this one. So we're going to keep it covered. We're going to stop infection getting in there. If there is lots and lots and lots of blood, again, 999, they're going to give you advice. They're going to make sure that you know what to do. Tourniquets, they are very useful, life-saving treatment. You may have to improvise a tourniquet, and that has saved lives before in the past. And one that I'm going to spring to mind is a girl called Bethany Hamilton, who lost her arm from a shark attack in Hawaii. And she is still alive because somebody used a surfboard leash to use it as a tourniquet, and it had the desired effect. It stopped blood loss, and the patient lived. So it does happen. It does work well. What I would say is if the blood is making you go, oh my gosh, that is a whole heap of blood, then utilize a tourniquet. We can always take it off when we arrive from an ambulance service perspective. If it's just a cut, keep it covered, stop infection getting in there, and keep the patient as still and safe as possible. Obviously, with wounds like this, if you're in a water environment, it's going to look a lot worse than it actually is. I've seen a lot of head lacerations where it looks horrific,
but actually when you get down to the source of the injury, it's a small cut because you've got the water and heads bleed quite profusely. So have a look, try and find the wound, keep it covered, and away you go. I'm moving on swiftly. Head injuries. So I've got kids. They hit their heads all the time. I don't take them all to hospital all the time. So think about the severity of the head injury. If it's a minor bump, then you haven't got anything to worry about. If a patient is concussed and they're confused, then get assistance, call 999. If the patient has become unconscious because of a head injury, then again, put them in a recovery position, put them on the side, make sure their airway's clear. You can have a little look at the pupils, make sure they stay reactive and the pupils, the black part of the eye stays the same on both sides. One bigger than the other could be a sign of a severe head injury. So it's small little things like that can make a big difference when you're, nothing you can do about it, but you can tell the ambulance service when they get there and they can provide more assistance with regards to head injuries. Again, moving on swiftly because I'm aware of the time, sorry. Spinal injuries. Difficult to deal with in a water environment. You know, there's a lot of training out there for how do we maneuver patients in the best method possible. What I would say, and it's definitely a Gordon Ingram rule of thumb, is do it safely, do it effectively, and get them to land as quickly as possible. Heads and necks, we worry about necks all the time. And then we're kind of focused on holding the head. You see all these medical dramas where they're holding the head and keeping it as still as possible and not causing any slight movement. If a neck injury has occurred in the injury pattern, in what has happened, you're unlikely to make the neck injury any worse by small little movements. However, don't start moving the head really, really obviously. Just keep it as still as possible, move them safely as possible to land, get them up the beach, use your paddleboard as a stretcher. Again, I've done that many times. Get them safe and keep them still and get help. If somebody has fallen into water and they've sustained a head injury, possible spinal injury, get them onto the board. And again, there are many, many courses out there which can teach you the best method possible to get somebody with a suspected spinal injury or head injury onto a board and get them through the surf or back to land as quickly as possible. All right. Moving on. Environmental, cold and hot. They're the two big ones. So what are we going to do? It's common sense. The essential things with this is if they're cold, warm them up. If they're too hot, cool them down. Get them out of the cause of the effect. So if they're cold, they're in the water, you're surfing or you're paddling at this time of year, especially up where I live. You can get cold. That's going to exacerbate worsening of the patient if they've got traumatic injuries as well. Try and keep them warm, get them out the cause of the cold, and insulate them. Don't take a wet wetsuit off unless you've got dry clothing to put onto the patient. Okay, keep that wet wetsuit on and keep them covered with other stuff. If you haven't got dry clothing to put straight onto the patient, keep them in that wet wetsuit and insulate them that way. If somebody's too hot, get them out the source, get them out the sun, get them into shade, give them fluids. Oral water obviously is the best and simplest thing to do. They may get confused, they may get agitated. Just getting them out the source, getting medical professional help as quickly as possible is going to save that patient. Okay. We're nearly at the end, don't worry. Drowning. Okay, so cardiac arrest, I mentioned drowning. As I said, there's lots of courses out there, lots of lifeguarding courses, lots of basic water safety courses. I said the word basic. Essential water safety courses, which can teach you the different techniques of saving a patient who's drowning. This changes slightly with regards to what do we do with regards to cardiac arrest from drowning as opposed to a medical or traumatic event. The emphasis for a drowning patient, if they're not breathing, would be ventilations. So on lifeguarding courses, you get taught that you give 5 rescue breaths. Basically, the drowning has caused the injury to the lungs and to the heart. So by oxygenating that patient as best as possible, and we're giving mouth to mouth here. So normally we breathe in 21% oxygen, we breathe out 16% oxygen. So when we give mouth to mouth, we're still giving 16. In normal life, we breathe in 21, we breathe out 16. So if my maths is right, that's 5. So we're giving 16%. So we're still giving more than we need in normal life. So that's a good thing. So give 5 rescue breaths, use the mouth-to-mouth technique, and then start compressions. That's the only difference with regards to drowning. If somebody's drowning, only go in and help them if you are trained to do so. Have to make that caveat. Always have a flotation device with you. And if you're paddling or surfing, you have one, it's your board. So utilize that as best you can as well. Do not detach yourself from your paddleboard or surfboard to help somebody else. So always have your lifeline attached to your ankle. Drowning, done, boom, moving on. Right, one other thing. All right, I'm gonna go back one. I'm gonna show you a fluoroscope. So lots of you out there would have done basic courses, essential courses in first aid. I still make the Freudian slip. And they'd have taught you how to open an airway. Now they'd have taught you that to open an airway, you do what we call a head tilt chin lift. Okay, and this is simply, most courses teach that a head tilt chin lift is getting the head and the chin and lifting the head back slightly. If you imagine I'm lying down on my back, it's moving the head back like this. I'm going to teach you why that's not quite accurate. Okay, so I'm just going to go back. I'll pause this at different times. If you, oh, sorry. Let me try that again. Play. Okay. If you look where I've paused that there, hopefully you can see my mouse. You can see that this jaw has been lifted forward. So up here, we've got the bottom of the jaw, teeth, top row of teeth, nose, head. Okay. This is the airway. And you can see that they've lifted this jaw, and this is an open airway. I'm going to press play in a second, and you're going to see what happens when you do a head tilt chin lift, which is just moving the head back slightly. So now they're going to move the head back slightly. Oh, I didn't pause. Sorry, people. Let me try that again. So there the airway's open. If you tilt the head back slightly, you can see that the airway is not open there, okay? So by doing a head tilt chin lift, as it's normally taught, head tilt chin lift is just moving the head backwards. It doesn't fully open the airway. If I move on to the next slide, this is a true head tilt chin lift. So that's it open. Now what they're going to do is a head tilt. Sorry, it's the next bit. Here we go. There's a head tilt and a chin lift. Now what you can see there is what they've done is they've done a head tilt and a chin lift. They've put their fingers underneath the angle of the jaw here and lifted the chin forwards. Now I've got more chins than a Chinese phone book, so it's quite difficult on me. So I lift the chin forwards and it opens up the airway. You can see on this slide that the bottom row of teeth is higher than the top row. And if you think about it, it's called a head tilt chin lift. It's a two-step maneuver. So just by tilting the head back, it doesn't open the airway. If you tilt the head back on an unconscious patient and you lift the chin, that's going to open the airway, and that's imperative. And you can see on the bottom, I've written this is essential. Not what is essential, as we've had all the way through this talk. This is essential. If you just tilt the head back on a patient and you expect the airway to be open, it's not. Tilt the head back, lift the chin forward, hold them in that position, and then their airway's open. Now, obviously, spinal injuries are different. We try and keep the head as still as possible, and we just do a jaw thrust, which is just lifting the bottom part of the jaw forwards, and we don't do the head tilt bit. But if somebody is not suspecting a spinal injury for whatever reason, then we do a head tilt, chin lift, and that's imperative. Okay? Moving on. The most essential thing of all, warmth, rest, reassurance. Okay? It's amazing how much help a patient gets just by being nice, having a calm manner, being a proverbial swan. You know, I am always the proverbial swan at work, hopefully. Some doctors and paramedics I work with might disagree with that. I always look quite cool and calm on the surface, but underneath and inside my brain, everything is going 100 million miles an hour. So try and be calm, even if you are stressed and worried and concerned about your friend who's injured or ill or unwell. Try and be that proverbial swan, give them warmth, give them rest, give them reassurance, and get help as quickly as possible. Any questions? Sorry it took so long. No,
to be honest with you, Gordon, you know, I could listen to this stuff for a lot longer. It was just a gentle nudge for you, but thank you ever so much. It's been really, I'm sure for some people that have not had any first aid training, I mean, that's a lot of info for them to digest, and fantastic, you know. And I think if you have an interest in first aid courses and taking this further and actually spending 2 or 3 days There's plenty of really good courses out there, and you know, a basic first aider, an essential first aider can save a life, and it's life-saving skills that we, you know, can really make a difference. So I would encourage everyone who's on the water, paddling regularly, to get some form of training. And my recommendation would also be, try to choose a course which is an outdoor rec first aid course, which is not your average 5-6 hour course, but one that covers the environment that you're working in. There's plenty of them around. There are obviously quite a few COVID restrictions at the minute, but first aid courses are running. And if anybody wants to ask any questions based on what Gordon has said tonight, even if you watch the YouTube presentation back, please email us at info@waterskillsacademy.com, and we'll get around to answering them for you.
Not a problem at all. I put my Twitter handle at the start. It's @GordonHems. So if anyone's got any questions as well, they can contact me direct. And not a problem. Any questions at all?
It's fantastic. And you know what makes it even more sincere is the fact that, Gordon, you are a paddler. You have come across all of these incidents that you've talked about. And it's a really good reminder, isn't it, for all of us, and the summing up at the end. And if there, you know, I'm not on a hard sell here, but if there any of the audience are interested in learning some essential rescue skills, the WSA, the SUP Water Safety and Rescue course is available, and we also do some beach lifeguard, surf lifeguard courses as well. So yeah, great. Stay safe, everyone.
Can I just say one more thing, Chris?
Yeah.
I just want to say, you know, people out there, if it wasn't for Chris, I wouldn't be sat here in my job now that I have the privilege to have. There's a bit of a backstory to this. I first met Chris when I was a young Geordie whippersnapper, went down to Cornwall, told him he needs to employ me. And from teaching surfing to lifeguarding to teaching lifeguarding, and all the way through my career, Chris has been there 100%. So thank you so much. Yeah,
thank you very much. And the rest is history, as they say. Yeah, thanks, Gordy. Thanks to everyone who's joined in. And we've got some more presentations coming up. Check them out on our Facebook page. We'll have our Wednesday CPD sessions, and we've got another free webinar on the Friday. I'm not sure if we've got one next week. I should know that, but I apologize now. But all the information will be on our Facebook page. Okay. All it leaves me to say is thanks ever so much, Gordon, and take care, everyone. Happy paddling if you are allowed to paddle. I think most of us are now, but there's light at the end of the tunnel, as they say, and have a great weekend. Thanks very much.
Cheers, everyone.
Yeah, cheers.
Obviously not ideal.
Thanks, Gordon.
Are we clear?
Nearly. Thank you.
No worries at all.
It's awesome.
No worries, Ben. Oh, I didn't realize what the time was.
Oh, no, it's brilliant. It's really, really good. I don't know where Chris is. He's probably nipped off to the gym.
No, I'm here. I had one ready.
Have we still got people listening in?
Yeah, just people saying thanks.
Yeah.
Yeah, brilliant. Thank you all.
Thanks, guys.
I'm going to shoot off. So thanks again, Gordon. Great to see you, and hopefully catch up soon.
Absolutely. It'd be good to go for paddle.
Cheers, Chris. See you tomorrow. Speak to you tomorrow.
Okay, cheers on the end of the meeting now.
Bye.
Yeah, bye.
Yeah.
Thanks, Gordy.
Cheers, mate.